Hello and a very warm welcome. Thanks for tuning in to another special webinar under the banner of Samajhdar Bano Sehat Ke Ishare Samjho, a CSR initiative by USV. We're trying to understand how you can mitigate your own, health problems and lead a better life. And this is under the banner of Samajhdar Bano Sehat Ke Ishare Samjho, a CSR initiative by USV. Today, we're talking about something that quite literally decides between life and death: heart attacks. But not just any heart attack. We're focusing on STEMI, or ST elevation myocardial infarction. Now, I do understand that that can sound highly technical, straight out of a medical course book. But think of it as simply one of the deadliest forms of heart attack where every single minute matters. Now, globally, there are proven ways of treating STEMI, but India, with its vast geography, its healthcare diversity, and the unique challenges that Indians face, needed something of our own. And out of that need, the STEMI India model, a care, was born. A homegrown system that connects patients, ambulances, and hospitals into one seamless chain of survival. Already, it has saved countless lives, and now it's drawing global recognition. And to take us through this inspiring journey, we're joined by the pioneers of this mission themselves. Dr. Thomas Alexander, Senior Interventional Cardiologist and Head of the Division of Cardiology at Kovai Medical Center and Hospital, Coimbatore. Many thanks, Doctor, for taking out the time. And Dr. Rajit Mulasari, Director of Cardiology at the Madras Medical Mission, Chennai. Both of these doctors, both of these gentlemen have been at the forefront of building, testing and scaling the STEMI India model, and we're honored to have them here with us. Before we dive in, of course, a quick note to all our participants and to the doctors as well that you'll have to be, you're going to be put on the spot. All these other people that are joining us on the webinar will be asking you their questions. We want this to be as interactive as possible. So please do not hesitate. Turn on your cameras. Aap apna haath utha sakte hain. You can raise your hands, drop your questions in the chat, and we'll take them forward with the two sublime doctors that are with us on the broadcast today. Towards the latter part of the session, we'll bring your voices into the conversation so that you can directly engage with our experts. Let's get started. Let's bring in Dr. Rajit Mulasari into the picture. Very warm welcome to both of you, doctors. It's such a privilege to be, sharing this panel with you. Pioneers of the STEMI model in India, the hub and spoke system. We'll talk about it all. But first and foremost, doctors, for all the people out there, just like myself, who aren't aware of what the STEMI model essentially is, why should the average Indian out there worry? What exactly is STEMI, and why should Indians now start caring about this?
Thank you very much for hosting us for this webinar.
The pleasure is all ours, Doctor.
Thank you. And what does ST elevation MI mean? It means it's an ECG diagnosis of what in common layman terms is an acute massive heart attack. Now, why this is important is that we talk about the golden hour of an heart attack. That means the first 60 minutes of treatment of a heart attack. It's very important, number one, to diagnose this problem. That means for which you need a simple ECG at a hospital which can take an ECG, a quick diagnosis that this is an acute heart attack, and then treat it correctly. Because if you don't treat it in the first golden hour, you can increase your mortality by 30%. And that's why we call that as the golden hour. So it's not only a diagnosis which is required, it is a speed of the diagnosis which is required, for which you need to have an ECG and a person to interpret it correctly. I mean, why am I saying interpret it correctly? Because many small towns and small villages, you may have an ECG done, but there's no doctor or a cardiologist who can make this diagnosis. So therefore, there is a big problem that, you see the doctor much later after ECG is taken, and there's a delay, and you will end up with complications. So the importance of STEMI is that it is a dangerous problem. It has to have a quick diagnosis. It is a common cause of sudden cardiac death. What does that mean? That means that people die at home suddenly, or somebody has a chest pain and collapses in your hospital or in your house or on the road. That's a common cause, is an acute heart attack or a STEMI. So the importance is diagnosis, quick treatment, and to refer to a correct hospital for the right treatment.
All right, so the golden hour, that's the operative portion here. Emphasize on that and how to save lives and, reduce, mortality, which you said increases by 30% if you don't take care in the first 16 minutes, of, a heart ordeal. Dr. Alexander, let's pass the buck over to you. In my introduction, we were essentially telling the viewers that, there is a global playbook that is available. But given India's vast demography, India's vast geography, we needed our own style and our own playbook. Why was the global playbook not enough when we're looking at the Indian context?
Thanks, Kabir, for having us here today. But okay, I think that's a great question and something that requires a clear answer, because what you're asking is, why did you need to reinvent the wheel if it was already available? Why didn't we just transfer a model that was available in the West straight to our geography?
Yep.
Now, you must clearly understand that the models that exist in the developed countries, say in US or Europe, are very costly and difficult to run in a country like ours. For example, you need the infrastructure, you need roads, you need ambulances, you need paramedics who are trained to reach a patient. If, for example, you call 911 in the US, you will get an ambulance arriving within 5 minutes, maximum 10 minutes in your house to pick you up. Now, this is clearly not feasible in our country. Again, patients can be transferred from their homes to a hospital within about 30 minutes in most parts of Europe and the US. And this doesn't happen in our country. In fact, if it's a rural population in the US or Europe, you can use an air ambulance to transport them. Now, these are very expensive and clearly not practical. So when Ajit and I, it was somewhere in 2010, we sat around thinking, what is it that we can do that is different to bring acute heart attack care to this country? Do we have to wait for all this infrastructure to develop in our country? And that's going to take maybe 10, 20, or 30 years. In that period, we're going to lose tens and thousands of our patients to heart attacks. Or is there a different way that we can work out a model that is really practical from the standpoint of the infrastructure and the manpower deficiencies that exist in our country, and make a program that works almost, or if not as well as a program that exists in the developed countries? And that was a challenge that we took up when we started this not-for-profit organization called STEMI India, which was registered actually far back in 2011.
So it's been a long, long, long journey, and on behalf of all the people that are watching this, or probably will watch it in the future because it's up there across our mediaverse. A big salute to the both of you, for bringing this about. Dr. Mulasari, what gave the two of you confidence? I mean, of course, I do want to delve into the fact when you sat back in the day and started thinking about this. How did the origin story is always of grave significance. Why did you guys want to do about want to bring about a revolution? In this STEMI model that we're now looking at? People are so interested in the origin stories of Wolverine and Superman, but not so much when it comes to STEMI. So let's educate the viewers on that particular front as well. What gave you the confidence, Doctor, that this homegrown STEMI model is going to work? Because Dr. Alexander just told us the complexities that and the challenges that come with our last mile connectivity. Can an ambulance go inside a little village, or really thin lanes? Can that actually happen? Air ambulances, people can't afford normal triages at hospitals, let alone forget about air ambulances. So what gave you the confidence that this will work, Dr. Mulasari?
So clearly, at that point of time, we were unsure, to be very honest, how we put this whole thing together. But we were confident about one thing, that the system which is described in the West is not applicable in India because it's just not viable, number one. Number two, we were clear that we will have to combine. Traditionally, the best mode of treatment of people with an acute heart attack is to get an ambulance, get them to a cardiac hospital, shift them even before from an emergency room to something called as a catheterization suite, do an angiogram, clear the block, and put a stent. That is traditionally the best way of treating acute heart attack. We call that primary coronary angioplasty. Now, this is the state of art of treatment of acute heart attack. in the more developed or the Western parts of the world. And this is what most people get in US or Europe. But the problem in India is not only the diagnosis, but to get an ambulance, as Thomas said, to quickly diagnose the problem, then shift to a hospital which has a cath lab, which is, it is more urban centric, these cath labs. They are not there in the towns, they are not in small tier 2 or tier 3 cities. And to have personal, you may have a cath lab in a hospital, but you need a 24/7 service. That means a doctor there who's capable of doing it, a nurse, a tech, to get the cath lab open and to get to doing things. Now, this was not at all possible in India at that time. So we had to look for another approach, which was common 20 years ago in the West, which was thrombolytic therapy, which means a drug, a clot-busting drug, which anybody can give, even in a small hospital, which has a small coronary care unit. So what we did was we thought that this is a combination of treatments which be possible. We can have hospitals which can give thrombolysis, which is an easy thing to do. Number two, hospitals which can have cath lab availability and give the primary angioplasty. And there's a third way. That means you thrombolyze a patient, and in case two things happen, if it fails, you shift the patient quickly into a bigger hospital. Or even if it succeeds, in 24 hours, if you can shift the patient to a major hospital, we can avoid the late complications of a heart attack in the smaller hospital. So which required us a way of diagnosing a heart attack, which at that time, as you know, there was no WhatsApp to transmit ECGs. And me and Thomas went about, even inventing an ECG machine to transmit from machine to machine. At that point of time, it was locally made. Number two is that it was extremely important to involve the government, because if you leave the poor patients out, this care will not be well possible and indefinable. But I mean, we wanted to create a model which can be lifted from Tamil Nadu and move to any part of the world. It's not only about developing and medium middle income countries, even to developed countries. For example, let me give you an example. In the United States, if you are in Minneapolis in the winter, in a small town, you will have heavy snowfall. And there's no way a patient can be airlifted in a helicopter from Minneapolis, small village, to the main town. So they have to thrombolyze the patient, and they cannot do without that. So clearly this model is even applicable to developed nations. So we created the mix and match model, and we went to the Tamil Nadu government and told them that, see, we want to involve the government hospitals. We want to involve the district hospitals. We want to have the small nursing homes, not the big hospital which me and Thomas work in. They have pretty much good systems of care within the hospital. Once the hospital reaches my door, you will get the best treatment. But that's not possible in most parts of India at that time. So what we created was we got the government to sign in, got the government Madras Medical College to walk in, the district hospitals, the government, the small nursing home, and created what is now the classic hub and spoke model, where you have a hub, which is a big hospital, and a spoke, which is around it, and they diagnose, and if they can fix the problem with a lytic drug at the point of care, they do that. If they can't, they shift to the major hub. And this creates a nice hub and spoke model, which mixes both public and private hospitals. So this was the first public-private sort of partnership we did in Tamil Nadu, which worked very well.
Well, thank you, Doctor, for very eloquently putting it. So you have the main hub in the center, then you've got some more spoke hospitals in its periphery, and the communication is going to be, of grave significance here between the spoke model and, the hub institutions. Dr. Alexander, I do want to sort of pick your brain in terms of what did this pilot project essentially teach you? What were some hurdles that came across? Because right at the beginning, both of you have mentioned that there is major discrepancy and deficiency when it comes to manpower. Very recently, if I could, give you a case study of my own, a family relative of mine, got a seizure late at night. We had to take them to the hospital. And there were people to conduct an MRI and a CT scan, but not many people to directly draw a medical inference of what that report actually tells you at that point in time. So I had to wait another 6 hours for them to for now sunrise to happen and doctors to come back to their chambers and then take that report to them. And that crucial 4-5 hour period could have been grave. Fortunately, that did not happen. God forbid it happens in the future to anybody of us. But there are challenges as well. So, what were the learning curves, Dr. Alexander? What was some of the teachings that the pilot project taught you, and what were some hurdles and challenges that came your way?
Okay, thanks, Kabir. I think you brought a number of points into focus when you spoke about your relative, and as we walk through some of the newer initiatives that we are in the process of developing, we will discuss some of these delays and how we plan to improve on them.
Yep.
But going back to the pilot project, I think there are two very critical factors that helped us to achieve to run the pilot project. The first was the Indian Council of Medical Research, ICMR, approved this project and funded the project. And that, I think, was a very, very crucial part of running the pilot project. The second was that the Tamil Nadu Health System project, or TNHSP, which is part of the Tamil Nadu Health Department, was an active partner in this project. And therefore, what they brought to the table was the public hospitals and the ambulance services. Now, apart from this, Ajit spoke about the technology team that worked with us, the software team that worked with us, as well as a number of private hospitals. So truly, this was a true public-private participation in this model that we had developed. This hub and spoke model, where we combined two forms of reperfusion or methods to open up the blocked artery. The smaller hospitals, by making them go through a process that we call pharmacoinvasive treatment, we widened the golden hour from 1 hour to 24 hours.
All right.
And you can see how that is so critical for a country like us. When you are talking about transporting a patient within 1 hour from a rural small spoke hospital to a hub hospital, within 1 hour, you can understand the logistical problems that arise there. But when you use this pharmacoinvasive treatment, you're widening your horizon to 24 hours. And that's what makes this so implementable in a developing country. Because now you can move these patients within 24 hours. There's time for your ambulances to be called, for the personnel to come and to transport this patient safely to the hub hospital. And what we found with the pilot study was that we were able to reduce the mortality to a level which is comparable to the best anywhere in the world by using these two methods of reperfusion. Whether you presented in a rural peripheral hospital, a spoke hospital, or whether you came to the hub hospital, which had a cath lab, it didn't matter, provided this was the way that the heart attack was treated. We were able to get mortality rates, in-hospital mortality rates of about 2 to 2.2%, which is as good as what you will get anywhere in the world. And therefore, when we validated this model, we were confident that we had a model that was as good as anything that anybody could get anywhere in the West. Now, hurdles, of course, this is the first time that we were running a project like this, getting the hospitals on board, training them. So there was a lot of training that had to go into them to teach not just the doctors.
That must have been an arduous task, Dr. Alexander. That must have been a tough and a huge hill to climb.
Yeah, absolutely. I mean, it's not just the doctors who need to be trained, because you can understand when you're talking about a system or a network, or what we call a STEMI network, right from the paramedics to the ambulance driver to the nursing staff who initially received the patient, to the ECG technician, to the doctor who finally makes the decision, and then transporting this patient. The whole team has to be part of this whole program. And that was a huge challenge. And I think teaching and going through this, I think was a huge experience. But I think the fact that we were able to bring down mortality by as much as 22%, relative reduction in mortality of 22% in a period of 9 months when we ran the pilot, I think that's why JAMA Cardiology, which is one of the very high impact journals in the world, accepted this paper as one of the pivotal trials that showed that this new model would work in a country like India, could be a forerunner of a program for many of the developing countries across the world.
Well, with the ICMR coming in, with the Tamil Nadu government now coming in, you pointed out this recent journalist who's accepted that paper must have instilled a lot of confidence in the both of you for what you started doing a couple of years back and what this system has achieved. Dr. Alexander, before I go on to Dr. Mulasari, you spoke about the two initial repercussion, techniques. What were they essentially? Can you refresh the memory of all the viewers here?
Ajit alluded to that a little while ago. One is the primary PCI, which is an
Yeah.
angioplasty, which you do if a patient presents to what we call the hub hospital, you have a cath lab and a team available, then the best form of reperfusion is to take the patient straight into the cath lab and do an angioplasty and open the vessel. The other is the pharmacoinvasive, where there is an initial medicine given in the small peripheral hospital. It widens your
Golden hour.
your window to do the invasive procedure from 1 hour to 24 hours. So you have 24 hours to move this patient to the hub hospital, so that you can then, if the vessel is not fully opened, you can go in and put in a stent.
Dr. Mulasari, I was just thinking to myself, when it comes to language, a national language is something that is of, political discord amongst all the states. When it comes to food, when it comes to cuisines, we can't have a national blueprint. India is that melting pot of diverse cultures and languages and people. A national STEMI network and system, do you think it can work when all these other things were unable to get on, a common line? One nation, one poll might still fly, but one nation, one STEMI, is it possible or not? That's what I'm trying to understand.
It's a tremendous question, and I think it's not something which happened only in India. That's the first thing I want to make it clear. Even the Western world suddenly one day did not get up and say, "Oh, we now have a system of care. And we're going to do it this way now." All over the world, the system started with the clot-busting drug, then primary angioplasty, and a lot of countries, even in the developed world, accepted these two modes. But what we brought onto the table differently was that the thrombolysis was followed by an invasive procedure within 24 hours, which was not well studied at that time. We were fortunate when we brought this on the table. In 1 year's time after our publication came in JAMA, there was an international study called the STREAM study, which got published in a major journal from Canada and Europe, saying the same thing, that we could combine these therapies and they both look sort of similar in this both ways of treating. So the first question got answered, that our treatment was validated by our study. It is now validated all over the world 1 year later by that this could happen. Now the next question is this diverse, language, diverse, hospital scenarios. We don't have a single system. We have a public health system in public hospitals, a private system, which is a different. There's a cash model, there is an insurance model, and there is everything, which is a mixture of everything. How can you put all this together? What we worked at that time with the government of Tamil Nadu was to put a public health insurance with an ambulance service of 108 for the public patients. The private patients did what exactly they do today. They have their insurances. They could come into their private insurances and get the treatment very quickly done. And what we opened up at that point of time in all the hospitals was a quick yes to the insurance. That is very, very important. You can, as you rightly told about your relative, if he needed a surgery or she needed a surgery at that point of time, if the insurance doesn't open up at 12 midnight, then you have a problem. You're stuck with this patient. Nobody carries, money in their purse to pay things. So we need to have that insurance 24/7 round, and that's what we ensured. We also ensured a public system ambulance which could fetch the patient to the either to the small hospital or from the small hospital to an inter-hospital transfer at no cost. So these were the successes that we bought a system. Let me tell you, the type of treatment doesn't matter. You can do an angioplasty, but if it's a delayed angioplasty or a slow angioplasty, it's not a good treatment. It is better to have a quicker thrombolysis than a delayed angioplasty. And this is what not many people know. And as physicians, we know that the more you delay, the more the disadvantage to whatever you do. So early reperfusion or early opening of the artery, whether it is medicines or angioplasty, is the mantra. Not trying to say that this is the way to go. So yes, what ICMR did after that was it was very nice for them to call all the secretaries of all the governments with us to sit down and see if this can be escalated to each state. And many of the states very quickly took over this process. And I'm happy to say that at least in some form or the other, the Tamil Nadu STEMI model is now being copied by many governments and being
Out of
used.
100%, doctor, how much percentage has it been implemented across the country? What would you say?
Well, it's a slow growing process. I think the southern states have been faster at it. Karnataka has done it. Telangana has done it. The northern states are still.
What about Kerala, doctor? What about Kerala?
Oh, Kerala is an outliner anyway because it has a very developed healthcare system.
Yep.
They have nothing called a village in Kerala. It's all towns. And each town, even then, had a lot of cath labs to service that angioplasty service. In fact, today, if you look at in Kerala, 81% of patients who get an acute heart attack will get a primary angioplasty today. No state even comes close to that. Now, the issue is that because of anything, it has developed a health system which is ahead, both in primary and in secondary systems of care. And I think that many states like Tamil Nadu, maybe Gujarat, and many of the more, I would say the richer states are possibly duplicating it faster than the poorer states, which have to grapple with their own problems and getting their infrastructure and people together.
You know what, doctor? I have a personal question of mine own to ask. This model, it connects ambulances and hospitals, and correct me if I'm wrong. If I've understood this, then I think the layman out there has understood this. We need that clot-busting drug to sort of open up our ambit to then carry out an invasive procedure, and that sort of extends that golden period from 1 hour to 24 hours, and that's the game changer that we're talking about. Now, how we do this is because we have a hub at the center, you have peripheral spoke hospitals, and the communication has to be right, which of course entails a lot of training. बहुत सारे लोगों को सिखाना पड़ेगा, बहुत सारे लोगों को इस टेक्निक के बारे में बताना भी पड़ेगा. But what's the most inspiring story you've personally come across during this journey? Yesterday, I was speaking to some people. They were telling us about this inspiring story about how a person who got a heart attack on a moving train, and then somebody on the train administered a CPR. Right at the next stop, they were pushed forth to the nearest spoke hospital, and then from that spoke hospital went to the hub hospital. So all of that, it actually can end up saving lives. It's a proud moment, isn't it? So any inspiring story, and this question is for both of you. आप दोनों में से कोई भी बता सकते हैं. One inspiring story that you thought you need to tell the viewers out there.
Let me take that privilege now. There was this patient which happened in Kowai, in Coimbatore, in Tom's Hospital. And this is a place called Odanchatram. Odanchatram is 120 kilometers away from the hub hospital, which was Thomas's hospital. Now, this is a poor man with just a card, which is a Tamil Nadu insurance card, comes to the Odanchatram hospital. If we had not put a system in place, what would have happened would the guy would have walked into the emergency room. Somebody would have said, "Oh, we don't treat heart attacks here because we have an ECG machine, but I don't think we have the capability to read the ECG or to make a diagnosis or give the clot-busting drugs. So please pick up the next car or train or plane or whatever you want, but to reach Coimbatore, and that will be 6 hours on a day without a busy traffic." So now that we empowered that small hospital by tele-ECG reading, by hand-holding them through the procedure, during their training, an ECG was done, a diagnosis of acute heart attack was made, the thrombolytic or the clot-busting drug was given with adequate preparation of medications. In 1 hour's time, Once the patient's chest pain was settled, the ambulance 108 moved that poor patient from that small hospital, which took another 5 hours. But here is a patient who's stable, whose ECGs are stabilizing after the clot busting drug. And Dr. Thomas Alexander was ready in the COI to receive the patient. We didn't have to wait for the patient to come to be called, which will take another delay in 20 minutes maybe to get everybody together. So by the time he comes to the hospital, he's taken straight to the cath lab, open the artery completely. The clot busting drug never usually opens artery completely. It opens enough to get circulation up, to get the pain down, to make the patient stable. But you fix the whole problem with a stent. And next day morning, the patient is discharged from the Coimbatore hospital, no bill being paid because insurance took care of the whole thing and the patient went home. So you have a state of the art care which happened from a small hospital in a rural center, using the system of care that we created and giving the state of art treatment for the patient with no cost to be paid by the patient. So this, I think, is a very important and inspiring story in many ways, that you could put a system together, a poor patient could be treated free, and most importantly, in my opinion, we upgraded that small center in Olanchhatram to a heart attack capable hospital. And today I'm proud to say that that hospital has a small ICU. They have 8 to 10 beds, and they've upgraded themselves. They themselves have the Tamil Nadu insurance scheme to treat the patient. So I think this is sort of inspiring, I think.
It is inspiring and morale boosting for that little hospital as well, that can then show and tell the world that, we helped and were a crucial part in this supply chain of hospitals, ambulances and doctors. And the greatest advent of it all, that Dr. Alexander was waiting on the other end to carry out that treatment. Many thanks, Dr. Alexander. The both of you are nothing short of superheroes. Let me again explain and emphasize on that point to all the viewers. The roadmap, Dr. Alexander, of scaling this, because I think the utopian vision is what Dr. Mulasari told us, was that Kerala has 81% of these hospitals that have cath labs, and I think the utopian setup is going to be that all of these villages become towns and we all have our respective labs. But when we're talking about scaling the national STEMI initiative from metros to remote towns, what do you think are the challenges? How soon do you see that happening and becoming an everyday layman word on the table? Like, everybody knows about what needs to be done. Everybody knows about this clot busting drug and how we can widen the scope of the golden hour.
Thanks, Kabir. And Ajit, I just wish we had an ability to transmit photographs at this point, because we have a photograph of the same patient with the technician in the ambulance who took a photograph of him while he was doing the ECG in the ambulance and at the time of discharge. Truly, something that I'm sure a person like him would never have been able to access care of that degree if the system was not in place. Okay, looking at how do we disseminate this whole program across the country. Ajit spoke about the ICMR meeting. So immediately after this project was completed, ICMR actually held a dissemination meeting in New Delhi when about 18 states participated. And Dr. Soumya Swaminathan was a DG at that time. Dr. Meenakshi Sharma was also part of that team. And what they did was to showcase what was done in the pilot project and request each of the states to take this project forward in their state. Now, what happened after that is the National Health Mission took up this to fund the projects. Now, one would expect that this would have rapidly disseminated across the country, but that has sadly not happened. It's taking its own time. The southern states are the quick adopters. So we now have Tamil Nadu, Karnataka, Andhra has now started their project. But some of the other northern states, also Punjab and UP, have also started it in a small way. But there are huge gaps, especially in the Northeast, where many of these programs have to start. But
All right.
interestingly, Kabir, I think you need to understand one other thing. Now, we started this hub and spoke model in a relatively urbanized state like Tamil Nadu. Now, we were asked to run this program by the Chhattisgarh state government, and we did a mapping. We do that as a routine to see what are the facilities available, what's the infrastructure available, and can we fit in this model into their health system. And we quickly realized that this model will not work in a state like Chhattisgarh because they had only one cath lab in the capital city. So if we were going to look at a hub and spoke model, this clearly was not going to happen there. So we quickly evolved into a three model framework, which is now what we advocate in different geographies. And this is based on the infrastructure, both in terms of medical facilities, as well as the medical personnel that is available in some of these states, which require, which are of very different. If you look at, say, Tamil Nadu or Kerala,
Yeah.
and you take the northeastern states, I mean, you can't compare the two, and therefore you cannot straight away move a model like this model directly to a northeastern state. So now we talk about a three model framework. States which do not have any STEMI program at all in place, we talk about Model 1, which is purely to give the clot-busting medication. And only if they have complications are they moved to a tertiary care center. So that's the basic model. The second is the hub and spoke model that we just talked about. We call that Model 2.
Yeah.
And the third is the Western model. So if you take very urbanized centers, take Bombay or Delhi, cath labs are available in virtually every suburb of the city. And it's possible for a patient to go directly, like whether by ambulance or self-transport themselves to a hospital with a cath lab and have a primary angioplasty being done. So, in fact, we are helping run one such Model 3 in the city of Cairo. So we are assisting the Egyptian Heart Society in running a program.
Wow.
So in Cairo, we run Model 3. And as you will see, the current guidelines talk about a three model framework for low and middle income countries, and they call it the STEMI India SSL model, which is the global model now for low and middle income countries. So we now feel that, and these are modular, as infrastructure improves, you can move from Model 1 to Model 2 or from Model 2 to Model 3. And I think that way we will be able to cover the whole country. Having said that, the protocols that we developed are now with ICMR, and some of that is being disseminated to the different states. We wish more states would take up the program, but it's been it's I think something that the public also needs to ask for, and I think a lot of public pressure onto your local government will force them to start these programs in their own states.
But the bottom line, essentially, what I've understood is that this is an ever-evolving process. I think the 3 model could very well become a 4 or 5 model as well. There's no stoppage on that as long as we're able to save lives, isn't it, Doctor?
Well, I think the 3 models virtually cover every scenario that we're talking about.
Okay. Okay. All right. So essentially, there's another question that's come on the. This question has been put across by Sana. Any of you doctors can take it. I think I'll go across to Dr. Mulasari next. All these people that are joining us. Again, आप सबको कह रहा हूँ कि आप अपना please camera on कर लें और अपना question chat box में डाल दें, so that we can directly line you up with the panelists and the experts with us on the broadcast, the pioneers of this STEMI model that we're looking at here in India. Doctor, one question has come across. It says a patient का 90% blockage है. How much of walking should this person do? कितनी walking करनी चाहिए दिन में for them to take care of a 90% blockage? Can we put a kilometer number on how much walking is advised or is healthy for a heart patient?
So the problem is the number 90%. Now, this 90%, it depends on which vessel is involved. Is it a major vessel or the small branch vessel? Number two, we have realized very quickly in medicine that the anatomic stenosis may not be determining flows. For example, a person with 90% may have no pain, no discomfort. He may be doing his routine activities without any discomfort. But somebody else who is 90% may have symptoms even at mild working or mild, day-to-day activities. So it's extremely important for us to understand that, the 90% means nothing as long as we know what is the territory where a major vessel is involved with 90% is more significant than a smaller vessel with 90%. Number two is what is your symptom status? If you have symptoms, it's important to see a physician, make a diagnosis, fix it if it is an important vessel, because you can't leave a 90% alone if it's in the main vessel and say, oh, come on, keep on walking and doing what you want, because that could lead to a disaster and an acute heart attack. So you need to fix the problem. And then you do whatever exercise you need. And finally, the most important thing in cardiovascular medicine is that this is a treatment which changes from day to day. It's not that angioplasty is one way of treating or bypass is the way you treat, but you can have various types of treatment at various points in time. A bypass patient 10 years later will get medical treatment because the bypasses may get blocked or they may get an angioplasty. If you get angioplasty, you will go on to medical treatment. And all these three modes of treatment are important. These are not different boxes. They are all same boxes put together in the whole thing.
There's another question that's come across from Abhishek. He says, रात में spicy खाना बहुत पसंद है. People go out for late night chais as well. And I think this is a question I would like to ask as well. Do our hearts secretly hate us for doing that? I mean, when it comes to food, we don't skip a heartbeat. We like to eat what we like to eat. It's spicy and, do our hearts hate us for that, or do they simply end up adapting to our, food choices and needs? I mean, because I need to ask the both of you. You're both in your, hospital scrubs, and which one of you is more likely to skip a workout? What is your own, success mantra? Do you hit the gym every day as well yourself? But Abhishek का यही सवाल है कि spicy खाने की वजह से do our hearts then adapt to that spicy food, or do they secretly hate on us and one day they just simply stop pumping?
Well, I don't think, Kabir, that the spice in your food is going to really affect how your heart responds to a blockage or not. So I don't think these are related. If he has, say, a reflux disease, clearly if he takes a spicy meal, he won't be able to sleep at night because with all of that refluxing up and producing a heartburn. But usually that has very little to do with the heart. Yeah, I think in terms of the exercise, I think I make sure that I do my 40 minutes of brisk walking. Mostly I do it in the mornings because that's because I know what my schedule is going to be. So I get up early and do that. But if I do come back home early, which is very infrequently, I might add on to that in the evening.
But that's it. Just walking is good enough, doctor?
Yeah. So I think it depends on the age. Depends on your fitness. Depends. But what I would suggest is that the sort of exercise is something that you need to be consistent with. So don't talk about, okay, I'll go play golf once a week. And use that as a form of exercise because you're doing it only once a week, or if you say go for a swim. I mean, I think whatever you're doing, make sure that you do it on a regular basis. What we generally advise is that you should do it at least 5 days in a week, which is the minimum amount per week of exercise that you do.
Roshan in the chat box also has a question. He says, रात को सोने से पहले चाय पी के सोता हूँ, कुछ आदत बन गई है, मेरे हार्ट पर इसका क्या असर पड़ेगा?
I don't think there's any effect at all. Don't worry about it.
Don't worry about it. Roshan, you can continue to drink tea before bed. People like to drink, some warm milk or some other supplementation, but I mean, tea is good to go as well. Sarita has also asked a question. Dr. Mulasari, maybe you can take this one. What changes in food, exercise or lifestyle can really help me reduce the chances of a heart attack in the future? And Dayaji has also asked a crucial question. I think let's address Dayaji's question first. Saritaji, your question is also going to be answered. Don't worry about that. Dayaji asks, if someone around me suddenly gets a chest pain, what should I do immediately before reaching a hospital, is what Dayaji says. And I think that's a crucial question. What happens when suddenly someone around you starts feeling some sort of chest heaviness, chest pain? What are some symptoms that one has to take a look at? And I think this also correlates with Abhishek's question, who says, Doctor, how can I know if I am getting a heart attack? What are some of the warning signs that I should never ever ignore? So let's start with that. Let's start with the warning signs that we should never ever ignore. That's Abhishek's question. Any one of you doctors?
So the first thing is, if I get an unusual discomfort in and around the chest or in the arm or in the jaw, which I've never felt in my life before, which is really unusual and bothering me, you should go to a doctor and a hospital.
But in what sense, doctor, if I could simplify this a little bit further, my apologies for cutting you short. What kind of pain, what is this unusual pain? Is it a striking, pinching pain? Is it, where in the arm should I be feeling that particular pain? Is it just like a little arm niggle that people go through? What's really happening? What's the exact thing that one should look out for?
So usually it's not a sharp stabbing pain. That's the first question. It's not like a pin prick or a sharp stabbing pain. But the pain characteristics can differ from people to people. For example, a diabetic patient may not get any pain or may get a very minimal discomfort, while somebody else who's not diabetic may get a pressure on the chest like an elephant is pressing on his chest, the sort of dull, compressive pain. The pain could be in the center of the chest, could go to the left arm, could go to the jaw, could go to the abdomen. So many parts it could move. But what I would like to say is, don't only go by the characteristic of the pain, because it can differ from person to person and you may miss the problem. The second part is, if it's very unusual, I've never had this before, and this is something unusual, the first thing you go is to a hospital, get an ECG done. There's no harm. Even if it's a false alarm, it's good to know that your ECG is normal at that point of time and your troponin test, which is a heart enzyme test, is negative. So that's very important to do. Most people think, oh, I don't want to wake up my spouse. I don't want to wake up my wife in the middle of the night. We'll get up in the morning and go. This, I think, is gas. They will take some Gelusil. And that's when the problem starts, because, you miss the early warning signal, your problems get worse. And then when you're really in trouble, that's when you start running. The other unfortunate problem is that most husbands and wives, only husband knows to drive a car, wife doesn't. There's no emergency numbers in your house. You may have all your friends' numbers, but there's no number for police or a hospital or a doctor in your house. I think everybody should have these numbers, which are all fire. In the US, 911 number covers fire, ambulance, and burglary. So we need to have some numbers with you to call people up and get things sorted. The second thing is if this pain is a heart attack for whatever reason, and it is, you have had a heart problem before and you think this is a heart attack, one thing you could help is take an aspirin. You can just dissolve it in water and take it. By the time the ambulance comes and starts picking you up for treatment, that's one thing you could do. But remember, don't try to sit at home and treat yourself. The other thing is, if you're a smoker, don't try smoking at that time. That's a disaster. Because people take the cigarette thinking that pain will come down if I have two drags on the smoke. And that sort of will kill you there. And I think that is very important that you don't do. And don't hesitate to call your wife or your whoever it is, or your children or your neighbor in case there's an emergency. Because time lost is heart muscle lost. And if you lose your time, you will lose the heart muscle and get inappropriate sort of treatment.
All right. The other question was that if somebody around me gets a sudden chest pain, and yeah, of course, Dr. Alexander, you can add on to that and also answer this question as well. If somebody around me gets a chest pain, what do I do immediately before reaching a hospital? Of course, Dr. Mulasari told us you can probably pop up a blood thinner before the ambulance comes. You can get an ECG done, but what more, doctor?
Well, I think one thing that a patient should realize is don't jump into your car and think that you will drive yourself to hospital. I think that would be the biggest disaster, because as your pain gets worse while you drive and you get an arrhythmia, I mean, if the heart attack doesn't kill you, an accident on the way will kill you. So it's ideal if you can get an ambulance to come and pick you up, and that's the best thing to do. So if 108 works in your area, if 108 is efficient at coming to pick up a patient, call your ambulance, because there is a paramedic on board, there is a defibrillator on the ambulance. So if you require an emergency medication, you need an emergency shock in the process of being transferred to a hospital, it's possible only in an ambulance. So keep your ambulance number. There might be hospitals that have ambulance services close to your house. Keep that number by the side of your or put it into your mobile, so that you know that you have a number that you can call, and an ambulance with a paramedic will come to pick you up. Now, if you don't have that, then get somebody else to drive you. Don't even think of self-driving. Get somebody else to drive you to the closest hospital.
All right. There's another question. Doctor, we've got Rahul who wants to directly ask a question. Let's see if we can connect and patch through to Rahul. You can ask your questions. Rahul, take it away.
Hello everyone. Firstly, thank you. This was so interesting. I was listening to the entire conversation. Now, looking at my age, doctors, you can imagine this. I am asking about my father. So he has an epilepsy problem, along with he has blockage also. So last year he had an attack. So how do you identify between the epilepsy attack, whether he's got a heart attack? That was my first question. And what are the emergency precautions we can take if something happens? Though there are some hospitals which are close by, but at such situations, you know how the panic mode comes on. So what are the basics we can take care of? And how will the service help? That's
Many thanks, Rahul, for your question. Who wants to take that? Okay, Dr. Mulasari, please go ahead.
Yes, so these two are different areas of the body. The epilepsy is from the brain. A heart attack is from the heart, you know. So there are two different organs involved. But let me put it, the caveat is that you may have a heart attack where your heart rhythm becomes either very slow or becomes bizarre, in which situation the blood pressure falls and the circulation to the brain is effective, and the patient may manifest as something like a seizure, like a fit. So sometimes there's a confusion whether this is a primary seizure or a heart attack creating low blood pressure and a circulation related issue and then a fit. The easiest thing is that usually heart attack patients, when they have a seizure, they're very sick. You know, their pressure is almost zero, so you won't feel a pulse there, number one. Number two, they will not have this classic movement, tonic-clonic, for a long period of time. They'll usually just fall, collapse, have a couple of seizures, and then be gasping or whatever it is. While a seizure is a very classic way, it starts with a sort of fall. It starts with a movement of the hand which moves upwards, then maybe the leg is involved, face is involved, frothing is involved. But always the pulse will be normal. And then if you feel the pulse, there's nothing wrong with the heart, it's all in the brain. So the pulse will be absolutely normal in such patients. So it's important that, yes, they could mix up sometimes, but a seizure, once you see it, and I've seen it once, you will know what is a seizure. And usually it will quieten down, and then they'll have a sort of a post-ictal phase where they're drowsy and unconscious. While a heart attack is not like that. If it creates a seizure, it's an absolute emergency. There'll be no pressure. And unless you do a CPR, the patient won't survive that sort of episode. So if you see a man falling and has a seizure and has a normal pulse, just feel the pulse. If the pulse is normal, it is likely to be a neurological seizure. But if the pulse cannot be felt or is very slow or whatever it is, then it's likely to be something from the heart, which is secondary triggered seizure.
Well, I hope that answers your question, Rahul. Many thanks for your question. At this point in time, Dr. Alexander, would you want to add something to that?
I said either way, call the ambulance, Rahul.
Yeah.
Oh, either way, call the ambulance. All right. Well, on that note, let's come back to a little bit of medical pedagogy again. I do understand these are highly, technical terms, but we do need to talk about it. We have to start somewhere, and I think this is that first step in that first right direction. Now, Dr. Alexander, how has SSL helped take this program beyond India's border? You've given us a little bit of a brief, given us some insights into that. And what's the story behind its partnership with STEMI India?
Yeah, so let me just give you a little bit of background about SSL. Now, SSL is a global organization that's based in Paris, and that's linked to EuroPCR, which is the largest interventional cardiology meeting in the world. Now, that's a not-for-profit organization, and it was set up initially to take heart attack care across Europe. Now, it was in 2009 that this whole program started, and by the time it was 2020, they felt that this program had actually covered all of Europe, and they were looking to see, can we take these programs to other low and middle income countries? Now, STEMI India has been a member of this organization. Today, there are 42 countries that are member of the SSL organization. So it was at this point that they were looking for what could be the program if we were going into the low and middle income countries. What would be the program that would be appropriate for these countries? And that's when they felt that the STEMI India program and the models that we had developed would be the appropriate models to take to low and middle income countries. So in 2020, I was co-opted as a co-chair of this global organizations. And they signed an MOU with STEMI India to utilize the protocols that we developed, the models that we developed, and the digital tools that we had developed to run this program to be utilized by SSL to run these programs in low and middle income countries.
Yeah, and the SSL
Now,
Ghati Global Alliance, it just wrapped up. Could this be a game changer, Doctor?
Absolutely. Now, Ghati is part of the American College of Cardiology. And you can see how these two organizations, one from Europe and the other from the US, have now signed an agreement to work together in low and middle income countries, again, utilizing the STEMI India model to take this program across the globe in Asia, Africa, and Latin America. And I think we're proud that we are partners to this, and that the model that is being used is the model that we developed here in India.
Incredible work that's been done by the both of you. Just to wrap this up, we're marking 11 years of the Make in India initiative today. The Prime Minister was speaking about it today. And, the STEMI India model is such a Make in India. It has all the ingredients to take this recipe right from the local most level to, beyond borders at the international stage. What do European cardiac societies say about its role in improving, care in the LMICs, Dr. Mulasari? The Make in India model, it has a global heartbeat, needless to say.
Yes, so there are two major consensus documents. One was published in a major journal called Circulation, that this model is good for developing and middle income countries. And the second is now the European Heart Journal Cardiovascular Care paper, which is coming up, which will say that this is the way that low and middle income countries should treat patients with heart attack and not stick to one model, which is Western. Let me also tell you one simple story.
Yep.
This is not true about low and middle income. You saw in the COVID pandemic how the systems of care got completely disrupted in the Western so-called developed nations. All the ambulances were running around picking COVID patients, and the acute heart attack patients were dying at home. And the problem was, a system can work only when everything else around it is working well.
Yep.
You have one pandemic like the COVID, taught you simply that acute heart attack completely was crippled the care. And, patients did not want to go hospital, so they sat at home. They didn't call ambulances. When you call for the ambulance didn't come because it was running around picking up COVID patients.
Yep.
And then when the patients were taken to the cath lab, everybody was gowned and covered and everything, and so much of delay that acute heart care was not proper. So I think that a disruption of what you say in a developed nation could happen any point of time. And this is something we should all know, that you should have a backup plan. When that happens, what do? Do you have another way of treating patients, like thrombolytic therapy or pharmacoinvasive care, which is more safer? And most countries went into that model at that time of the COVID. So it's not only LMIC, it is also upper income countries when their systems gets disrupted.
All right. I think we'll leave it there. We've had a riveting conversation. Our earlier segments on heart attack and diabetes, I think, answered a lot of questions, what they can do in their day-to-day lives to mitigate something like this. But now that we're here finally, and we're talking about prevention and increasing that golden period, about those clot-busting medication, and this incredible work that you've set out with the pilot project, and now that's been implemented and integrated. Let's hope very soon across the length and breadth of the country. But on that note, thank you so much, Dr. Alexander and Dr. Mulasari, for your time, for your insights, and above all, the incredible work, I'm saying it again, for what you've done to shape the STEMI India model of care. What we've heard today is more than just medical detail. It's the story of how Indian innovation, persistence, and collaboration can literally save lives. A story that shows the world that healthcare solutions can be made in India, but with a truly global heartbeat. To all our participants as well, Sana, Abhishek, all those that were mentioning those questions, Roshan as well, and Rahul, don't forget to call an ambulance either way, whether it's an epilepsy attack or a heart attack. Even if you're unsure, call an ambulance either way. To all our participants, thank you so much for joining us and making this truly a successful project, for your thoughtful questions. And we've learned today, in the case of STEMI, every single minute matters. Awareness, quick action, and a connected system can make the difference between tragedy and survival. This is not just a doctor's mission or this duo's mission, it's a people's mission. And by understanding these signs, by spreading awareness in our own cities, I've been educated today. I hope the same happens for you as well. Each of us can be part of this chain of survival. On behalf of Samajhdar Bano, Sehat Ke Ishare Samjho, a CSR initiative by USV, we are again thanking you once again for being with us. Let's carry forward the message that informed citizens can help build healthier communities. Stay aware, stay safe, and until next time, take care of your hearts.